but I want to ask you for a little bit of attention. I will present a new lens from B+L, which is Luxsmart EDOF, and it might be a good opportunity for presbyopia correction in routine and challenging cases also. This is a picture which I have done of the Luxsmart with stereo coaxial illumination, because I rarely trust the industry. I don't want to take for granted any info which is given. I want to see it by myself. So here you can see some rings. These are transition zones or modification of the optic or something else. So we know that this is the central area of the IOL, and it is really important to remember that is 2 millimeters of size. What is the meaning of that? We have at least 1 millimeter room for visual axis offset. So this lens is forgiving when it is decentered. And it is a very important feature which I will later show. Here is the second zone of the transition, and this is the design of the lens. I will go a little bit further. We know what is spherical aberration, but do we really understand how it might affect the image? The spherical aberration is any deviation from the shape of the perfect sphere. So if it's steeper, it's positive. If it's not so steep but lower than the normal curvature, it is negative. Here, this is the principle which is taken from the microscopes and telescopes of balancing the 6th and 4th order spherical aberrations. What can be achieved? It can achieve extension of the visual range or the focal range of the system of at least 1.5 diopter. If we turn the picture horizontally, we can see that the first bump in the balanced curve of the wave front. So, too many complicated words, but what is the meaning of that? The first bump is the central area, and the second plateau is the transition zone. And this is the principle of action of this lens. We have extension of the visual range without sacrificing of the quality of the image. So we all know what is angle kappa. Angle kappa is the angle between the visual axis and the pupillary axis. And we know that there are some lenses which are really sensitive to decentration. Not the case with Luxsmart here. Now, here this is the wavefront of implanted Luxsmart, and you can see with the crosshair where is the landing zone of the visual axis. So, large central zone, more independent from angle kappa. Here, there is another thing, no influence over refractometry. We know that from other manufacturers, there are lenses which might fool the refractor, and we need to use the manifest refraction, not the machine-taken one. Not the case with Luxsmart EDOF. Now, here, this is a competitive EDOF IOL, and you can see the small central zone and where is the landing area of the visual axis is exactly on the transition zone, which might contribute to unwanted light phenomena. So, here is the pictures, Luxsmart and the competitor IOL. So you can clearly see the difference between the both designs. So that is why we are talking more and more for monofocal plus, for extended range lenses, for near dominant EDOFs, far dominant EDOFs. So we as surgeons, we need to know what technology we use and on which patient to, let's say, offer this technology. Here, this is another publication, optical bench analysis, which compares two lenses. Of course, EDOF. Luxsmart is the lower one. The upper one is the competitor. The main thing that is seen is the light. The competitor is a little bit less forgiving on the contrast. The Luxsmart preserves the light. There is a sort of triangle of light, which is light intensity, depth of focus, and horizontal resolution. If you decrease the light intensity, you will lose depth of focus and you will lose horizontal resolution. Nobody can escape the physics, and as Professor Alfard said, there is no free lunch in optics. So I want you to remember the difference here. Patient selection. Some patients might seem cute and fluffy, but they have a lot of expectations. So in my practice, the best candidates were emmetrops and hyperops. Not only were, they are still, but high myopes are not happy if targeted to emmetropia with Luxsmart EDOF and other EDOF lenses, which are adding roughly diopter and a half range of vision extension. So one of the possible solutions in high myopes is an office progressive strategy to target to -1.5, and they are actually happy because their vision, they want near vision with high contrast. They don't care so much for their far vision because this is their whole life habit to see perfectly well on near. Mini monovision is absolutely viable option when we are playing with EDOF lenses. In case of the Luxsmart, if we implant the dominant eye to plano and the non-dominant to -0.5 or 0.75, the patient is more or less glass independent of his daily activities. But keep in mind the magic phrase: you will need +1.5 diopter reading glasses for small prints, because if you skip this phrase, later on the patient might ask, why I need to use glasses? Why I'm not glass independent? So we need to sort of ensure ourselves and also to be sure that the patient comprehended our conversation for what we are offering and what he will receive with the Luxsmart EDOF lens. Something really important is always consider surface problems before implanting any EDOF lens. Why? Because it might be a source of preoperative and postoperative issues. Preoperative, of course, wrong keratometry, wrong topography, and thus wrong biometry and refractive surprise. Postoperative, we need to know that there is no single EDOF lens on the market which can provide crisp, sharp, pilot-like far vision. There is always compromise. On top of that, if we have not uniform tear film and surface issues, it will further degrade and the patient will be not happy at all. So, dry eye management before and after surgery. The magic rule: don't compete with multifocus. Luxsmart and any other EDOF is a new opportunity between monofocus and multifocus. We can go even further. The multifocus will self-extinct actually. Why? Because all the major brands which are involved with the EDOF lenses, they go for high near at variants of their existing IOLs. So B+L will have it, Alcon will have it, SIFI presented already a lens with such a design. So we need to know the human eye is a refractive system. Why we need to go making it diffractive system? Here, this is the recommended way of loading of the B+L Luxsmart. It's actually preloaded, so the correct word is preparing for injection or implantation. First, we need to use BSS. Later on, we need to be sure that the BSS is fully covering the cartridge and the IOL. And we need to close the cartridge, of course. Sometimes I'm a little bit cautious about the silicone plunger which might not enter completely well the channel of the cartridge and might damage the haptics. But the truth is that the lens is hydrophobic, which is important, and is fairly rigid to external, let's say, forces. So here you need to fill with OVD the injector, and it is possible, wound assisted, the lens to be delivered through 2.2 millimeters incision. I always check if the lens is advancing without issues, and with good amount of counter traction, we can introduce the lens in the back. The optic and the material is really forgiving and unfolds slowly as we would expect from a hydrophobic lens. The design is well-known design with 4 haptics, which provides a stable position in the eye. Here, this is another way of loading it, which I think is a little bit easier. You just fill the cartridge with OVD, and not from the tip of the cartridge, but behind it, because from the tip of the cartridge I think it's a little bit more difficult. So the main idea is to cover everything with OVD in order to glide smoothly. Then again we check if it was advanced without any obstacles, and again it will be wound assisted implantation. Again, repositioning can be done with a Sinski hook or a spatula, or even with the tip of the irrigation aspiration cannula. So here is a fairly regular case of operation with Luxsmart. This is a hyperopic eye, and we normally aim with a normal rexis, something around 5.5 millimeters maximum, in order to have a good coverage of the optic with anterior rexis. I saw that a lot of things were said about the calculations and formulas which are used. And I saw that there is a lean of artificial intelligence supported statistical modification of SRKT formula, because all the, let's say, derivatives of SRKT actually rely on a statistical modification of subgroups. I talk about Kane, I talk about Hillerbev, I talk about Ladas from UDEDEVGAM. And what I don't like of these formulas is the fact that they don't relate at all to the measured eye. They just mathematically approximate what will happen. I normally use Olsen and ray tracing formula because the calculation is directly connected with the measured eye. I suppose you're all familiar with the so-called C constant, which is based on a lens thickness. So I would advise always to compare a ray tracing method of calculation with the statistical ones. Here we advance the surgery, irrigation aspiration, and now a normal implantation. And simply we can push the lens. So it's more forgiving during the implantation compared to the hydrophilic plate haptics, which sort of expand immediately in the anterior chamber. Here, I said that there will be challenging cases. I have here a posterior polar cataract. Why I chose to implant Luxsmart? First, because the platform is good for alternative fixation solutions if something happens with the posterior capsule. We might expect that it will spontaneously open here, and we need to find a way to fixate our lens. One of the ways would be to fixate it with diagonal haptic fixation to the anterior rhexis. That is why my rhexis here is a little bit smaller. Or if I cannot do this, I can always fixate this lens to the sclera. I always do hydrodissection, not hydrodelineation, in posterior polar cataracts, because I believe that there is no more gentle thing than the wave of water in order to separate the posterior cortex from the thin posterior capsule. We know that the posterior polar area is thinner than a regular capsule. Now, here I got lucky probably. I don't have any PCR. Now, carefully I remove the residual cortex. I like to use it with, to do it with bimanual irrigation aspiration, because in that way I can reach any place of the anterior chamber and I can control the movement of the eye. The filter is applied on the image, that is why it looks unnatural, but I believe that I see better the transparent tissues with this filter. And the implantation. And after the surgery, nobody will know that here there was a risky situation, like a posterior polar cataract, which normally scares all of us. Here you can appreciate the rigidity of the material, which sometimes is a benefit, sometimes might not be a benefit. So that's it. And the most challenging situation was the trauma of a child which is 11-year-old, blunt trauma, on which I chose again to implant Luxsmart. Why? Because it's hydrophobic. Also because it is EDOF with at least 1.5 diopter range of depth of focus extension. And if I have a mistake of my calculation, I might have a diopter and a half window to land this mistake there. Also, this is a child. If the refraction somehow changes, we still have diopter and a half window in which it might be compensated. Also, if we are plano, the child will have some functional vision in not only like with a monofocal lens, but something around 45-50 centimeters. As I said, the design of the lens allows to be Gore-Tex fixated as acrylic AO. this is a technique which is different from the well-known, because all the surgeons are passing the Gore-Tex sutures outside the eye. They make a large incision and then they implant the complex with the sutures. Here, with handshake technique and the proper instrumentation, it might be done without enlarging the main incision. I'm using a horizontal scleral pockets because I will be able to hide the sutures under the sclera, and later on there will be no visible signs of such a complex fixation. This was the first part. The iris was torn, so iridoplasty partial one was made already on 3 points. Then the second half of the lens. It's quite useful to have a micro tools for anterior segment because of the curvature, which makes them more natural for us to move in anterior segment. Of course, it might be done with vitreoretinal instruments, but it's tricky because they are straight. So here, this is the second Gore-Tex suture. Why Gore-Tex? Because it will be a lifetime longevity of this fixation. It will not degrade after 10 to 15 years. And this is a child, 11 years old, so hopefully he will have a lot of years in front of him in this life. Now, carefully, we can titrate the tension and the position of the IOL. We always need to do that on a pressurized eye. I have a leaking valve. It's an issue, but still, the eye is with normal pressure. So, next step will be to try to form a shape of the iris. Why I didn't go for iris circlage? Because the maneuvers which are required to perform iris circlage might lead to additional root tearing of the iris. This is a blunt trauma. We don't know how is the angle and how the iris is damaged even more than the visible damages. So here I'm using a ProLane suture with a 14 millimeter needle. This is an Alcon PC9 suture. It's good because the needle is strong, so you can guide it more or less easy. And I will use Sipser sliding knot in order to complete the iridoplasty. I sort of made my own instrument, horizontal hook, which I find really helpful in such maneuvers, because there is a vertical instrument, vertical hook, which is available, but there is no available horizontal one. If the hook was vertical, I wouldn't be able to remove it from the side port without twisting the instrument. So a small detail, but obviously important. And the beauty of the Sipser sliding knot is that all the timed maneuvers are done outside of the eye. So it started to look a little bit better than in the beginning of the surgery. So with that said, I think the Luxsmart might be a really versatile solution as a choice for a, let's say, premium presbyopic surgery, but also as a choice in challenging conditions. Thank you very much for your attention.